I'm happy to take questions, and thanks for your attention. Evangelist, sure. Yes. So, yeah, because we're being beamed around the universe by Facebook, right? Okay. Hello out there. The question was, in our study, Millichap et al., everyone, it's freely available online, Neurology Genetics, paper 2016. How did the older patients do in terms of seizure control? And the answer is that we don't have a complete answer, but by and large, the patients that were in that older group were not having frequent seizures. And so the reason we divided it post hoc at 6 months was that was where the patients were having frequent seizures, and we saw, as the drug was introduced, a dose-related loss of seizures and in some cases periods of seizure remission. But the older patients, it was a really, because the way the study was conducted, it was really a retrospective survey. We didn't have the ability, the patients were actually de-identified and reported to the individual site investigators. We had limited ability to do what hopefully we can do through these new natural history studies that are now emerging and get more information about development. It's just a limited study. Yeah. Any parent questions? Sure.
KCNQ3 onset. You kept saying later, but then you said childhood. So is there like an age you guys have, or is it just kind of like a year? Like, what's the on KCNQ3?
Well, I was somewhat deliberately vague because I always hesitate to talk to anybody, but including parents, about work that is still in the process of being prepared for publication. And one of the reasons is it's hard to keep track of all this information. A paper is a really good way of just getting it right and double and triple checking. But the basic pattern in these patients is that they have no neonatal onset seizures. They have no infantile spasm, which is usually the peak is in the middle of the first year of life, though it can extend. And instead they have developmental slowing, which is appreciated in the second half of the first year, but they may not see a specialist until the second year. And then when they're coming in, it's for intellectual disability or developmental delay. It's not for seizures at all. Many of them never get an EEG, and so some of the patients don't get an EEG until they're 15 years old. And the range is between 2 years. So we don't know about any of these children as infants because we haven't had one tested before the age of about 2, and the oldest one's about age 23. And the vast majority of them haven't had a seizure. But they still have a very unusual EEG that means something specific to epileptologists and helps with decisions about treatment called, it has a long name, electrical status epilepticus in slow wave sleep. That's the longest one I've ever come. But there'll be more to talk about, and I think that's going to be a larger patient group because whereas neonatal seizures come to medical attention very quickly and often get an EEG, patients with this syndrome, the vast majority of them have never had an EEG out in the community and have never had, certainly haven't had a KCNQ test. And once our paper comes out, we expect that there's going to be far more testing, both genetically an EG, and suddenly we'll have a not such a rare thing.
Ed, there was a question if there's
Yes.
any advancement that you're aware of in terms of gain of function, drug updates. A lot of the points are around loss of function. So any...
Yeah. Yeah, well, there's several parts of that answer. One I'm not going to say a lot about. I saw Matt Fox here from Paranomics, and they conducted a compound screening set of tests for the R201C variant, and their study shows that a antidepressant medication called Paxil or Paxilotine, if I've got it right, was a blocker in that setting. But I'm going to let others comment on that more. There are other potential strategies. One is as these patients become more common and known, more high throughput screening could be done. And the other is that there are known selective blockers of KCNQ channels in general, some of which have been tried in man. There's the drug called linoperdine as a sort of model compound that was tried for close to 20 years ago for Alzheimer's disease. At one point, there was a connection between the M current and Alzheimer's disease in the scientific world. And so a drug that turned out to be a KCNQ2 or KCNQ channel blocker was developed and tried in hundreds of adults with early Alzheimer's, early onset Alzheimer's. So I think that as we know, even though the KCNQ 2 and 3 gain of function are always going to be less common than the KCNQ2 loss of function, there are going to be other patients that come out of this new study, and essentially higher throughput efforts have some leads in the known pharmacology. I saw another question for a while. Sarah, Ingrid, are you gonna hesitate not ask? What did I do wrong? Thank you.
Just a beautiful job. I actually had two questions. I'm sorry, you're going to be
No,
sorry
that's
you
good.
asked me.
It's parent and professional.
The gain of function ones.
Yeah.
What I'm worried about is, will we be able to tell at birth which a child has if they don't have a recurrent, well-tested one? And how quickly can you do functional studies in that first week of life to know whether you should use something like ezogabine or another potassium channel opener?
I think the main barrier is not access to really rapid functional testing, but to adequate penetrating the market of clinicians with what we already know. So I think that the descriptions are different enough that it's, for a real expert, it's possible to see the difference between the usual KCNQ2 loss of function and this myoclonic syndrome that we worked on together. And then what we can do very quickly is we can do gene panel testing. There's no reason we can't do gene panel testing in 2 days, except that it's not the usual workflow. It's a fast the assay takes a couple hours. It's not. We've gone from 4 months. Who here had a gene panel test that took 4 months, right? And now most patients in the U.S., if they get to the right lab, it's in 2 weeks, but it can be faster. And so I think the combination of astute clinical, the third component is the registry itself, is that the number of novel variants is going down rapidly, that we're going to very quickly saturate the variants, and so there will be once you get a genetic test, you're going to know what you've got. You'll confirm what an astute clinician like yourself or Roberta or our other colleagues will already kind of have a suspicion, and then they'll get the result, and they know what they're dealing with. In a way, the name KCNQ2 encephalopathy is kind of a problem for us. We need to sort of market them as different diseases without becoming really tribal in our other efforts. We have to market to the average pediatric neurologist, forget the neonatologist, but to really have in mind that these are different disorders that need a different path forward and have a different prognosis. And it's a genetic test that it'll be clear after the genetic test is done. There are no variants that are either, just like there are hardly any variants where it's unclear whether it's BFNE versus the EE. I'm not a big fan of that there's much variable expressivity for loss of function variants. I think almost always, there are a few on the fence ones, but basically if it's heterozygous and it's a KCNQ2 loss of function mutation, almost all of them fall only on one side or the other, is my view. Not universally held, by the way, in the literature. That's my opinion.
So that's very helpful. The second question was around, I think, the KCNQ3 encephalopathy, where you talked about them having intellectual disability, autism, and gain of function mutations. I'm just hoping I'm not confusing it all.
Correct.
And you said that they had electrical status epilepticus in slow wave sleep, which we call continuous spike wave in slow wave sleep.
Even longer.
Even longer. But the question I had was about that. You said they have no seizures, which we know is quite common in CSWS. But the CSWS kids that you see normally have regression.
Yeah.
And nowadays we treat children with CSWS with high-dose steroids, often for many months.
Yes.
So my question to you is, do these KCNQ3 encephalopathy children have regression, developmental regression, and have they responded to steroids prior to diagnosis?
Okay. So I think, how is it different from ESES or whatever the other acronym is? It seems that the ESES, the abnormal EEG, occurs early compared to the previous broader group, so I'm saying age 2 to 4, not age 4 to 8. And in our case series, as you may know, and I'm not sure you do, but the several patients were not treated with steroids, which is one of the drugs that's been shown to be of benefit in patients, but instead with high-dose benzodiazepines, basically Valium. And those patients had improvement in their EEG and variable improvement, again, low N, multiple sites, no protocol. So limitations of method in a rare disease. Variable improvement in their development. But I think because these patients present the onset of their developmental impairment is quite a bit earlier than the usual range for ESES, it's less clear to me that there's good development until the emergence of seizures and ESES and regression. It's more that they were developing slowly as late infants, and that being said, some of the patients have lost words. Some modest early indications that there can be regression. Yeah. Yes, Carolyn.
So, kind of building on some of Ingrid's comments of being able, and you were saying you were able to tell what's turns out to be more of a BF&E presentation compared to the epileptic encephalopathy, whether within given variants, now that we're getting more and more children and seeing the same variants popping up over and over, are you able to have some kind of prognostic ability of what the outcomes are going to be depending on a particular variant, where particular variants end up more or less severe? Because some of the children we're seeing have the same variant, but then are having much different outcomes even with the same variant.
Right.
At least it's appearing that way, and what you attribute that to, or whether, as we get more and more patients, we're being able to know a little better what the outcomes are for this variant versus another variant.
Well, I just agree with everything you said, and the only thing I would add, so you were asking, well, how far can you push the idea that a specific variant accounts for what we call phenotype, which really means just the degree of, how the child is affected, the severity, and I doubt that it is. That I wouldn't suspect that all the patients with the same variant would be exactly alike in their severity. Now, but on the other hand, I think it's a big factor, and so what you've described, this question, that's the motivation for doing an actual natural history study. It's impossible using the data that we have to answer it now, because we really have to compare the patients systematically through some a specific inventory, and then we'll have answers for that. But what I imagine is that although children that have EE and a highly recurrent variant might be different in how they're affected, it's relatively less likely that that variant is going to cross over into the BFNE group where you wouldn't expose the child to the risk of a trial drug. It's much more likely that there's a spectrum of sort of mean severities for the variants, that those mean severities are related to the degree of in vitro current loss, and that it doesn't usually cross over into the BFNE category where there's negligible risk of a developmental problem. So it's more that for, T274M is a highly recurrent variant, or 290, or 294, where we have 17 or 18 patients at that codon, 265. These are the common ones. Well, those individuals with those variants that are all de novo, all unrelated individuals, neglecting the mosaicism, heterozygous individuals, they're going to range, but they're going to range in the developmental impairment range, where any child born with that variant, I'm going to be able to, or Ingrid's going to be able to, in good conscience, go to the family and say, your child is, as far as we know, destined to have a disorder that's going to affect their whole life and their development in a way that is really impactful. And so for these reasons, I offer you the opportunity to go into a trial with an untested new drug. And we can eliminate the BFNE ones because those variants have been passed down through the generations, and we have a good catalog and growing catalog of them. The missense BFNE variants are the only hard group, and that's why we have to know about recurrence, and that's why we have to sequence BFNE families more than we do, and report them much more than we do. It's a real problem that most BFNE families don't get sequenced, and those that get sequenced don't get reported, except in Australia. Why are you nodding? You can't get them either. Well, that's how it feels when you're rich. It's never enough.
Okay. All right.
Okay?